Good morning, everybody. It's 10 o'clock on Pacific time right now, and we're about to start our BHCOE business meeting recap from the Association for Behavior Analysis conference that we did about a couple weeks ago. I can see we have a couple people joining us, so feel free to use the chat if you have any questions as we're going through this, or use the Q&A system. What I'd like to do is just recap what we went over in the accreditation process through that business meeting and talk to you a little bit about our annual report and some of the updates that we've had. Before I get started, I want to do a quick audio check. So if you wouldn't mind just using the chat to let me know if you can hear me okay. And we can get started once we get some confirmation there. Can everyone hear me okay? Let's see. Okay, perfect. Great. Nice to see all of you. I see Sarah, Autumn, Daniel, Crystal. It's wonderful to have all of you here. The great thing too is that we have people from all over the United States here and some other countries as well. So I'm really excited to share some of those updates with you. So I guess stay tuned, and I will be checking that chat periodically. So if anything comes up that's of interest to you, just let me know, and I'll try and get through them as we go. So today what I'm just going to be talking about is just some of the impact that we've made over the last year, and that will cover our accomplishments and some of our future directions. And then I'm going to talk about some of the updates that we've made to our other accreditation offerings, to our standards, go over some of the preliminary data that we've gotten from our turnover and hourly data, go over provider awards and some future directions. And then at the end, I'm going to leave some time for a Q&A just so that you guys can pose some questions about where we're going and what we're doing here. So I know that this is something that all of you are very aware of, but I always like to start these presentations because we do them annually. So if you notice, we always do this in June, where we have all our providers come around and talk about what we've been up to. But the important thing to remember is the purpose of accreditation and what it is. And accreditation is essentially just a certification that's given to an organization that shows that it's demonstrated someone has determined that they've met a certain set of standards. And the reason why accreditation is really important for our field is that it's important to create an internal standard on our field before an external standard is imposed upon us. So what we're finding in some funders is that you're getting some pushback from funders as to the way that behavior analysis should be practiced. And so what we hope to do is, as a field, really come together across one set of standards that we can kind of agree upon internally, so that we can help those funders better determine how we should be practicing in a way that allows us to provide the best outcomes for our patients. The other component is that we're all really big fans of peer review. I mean, we have that standard for our journals, and we understand that that's something that we are doing, when we're in graduate school and when we're publishing, but sometimes we forget that peer review is also important in terms of clinical quality review as well. And so this is just another method, a more formalized method of getting peer review for your practice. And then third, ABA is now a medical benefit, and accreditation is something that's required across every other medical industry. And that's something that we're really hoping will be required for our field as well. It's important to have some type of higher standard that organizations are held to, that's not just holding the individual accountable. And then lastly, I'll talk a little bit about this, but some payers are moving towards a value-based payment system where they're kind of looking for demonstrations of quality indicators and kind of looking for patient outcome long terms. And I'm going to talk to you about what we're doing to try and deal with these challenges and help move the field along as well. So what I'd like to do first is talk a little bit about what we've done in the last year. So these are some of our cumulative growth numbers from our inception. So for those of you familiar with how we've started, back in 2015, we piloted the program with about 8 providers. This is from DDS. We moved from the DDS model to the BHCOE model. And so those 8 providers, some of you are on the line here, so those piloted the program. And then in 2016, we rolled out the accreditation for 52 organizations who were involved. Since then, we've had 101 go through the process as of December of 2017. And I'm excited to report to you that as of the ABAI meeting in May, we are at about 135. So what we're seeing is really steady growth. And we're also seeing that we're moving across different states as well. So this is what it looked like in 2016, and this is what it's looking like now in 2017. So you can see that not only are we getting more saturation in some of the larger states like Texas and Illinois, but also we're filling in some of the other states. We still have some other states that we haven't worked with too much, and those are usually ones that tend to be smaller in terms of the population size, the number of board certified behavior analysts, and also some that haven't had that autism mandate pass yet, which is really important. So those are areas we're looking to work in, but we also know that we kind of have to work with the market as well. So if the funders aren't there and if the services aren't there, then oftentimes we find that we're working a little bit more heavily with a developed market. So that's why you'll find some of those other populations more heavily, heavily saturated with accredited providers. So these are some of the areas that we really aimed to focus on in 2017, and I'm really delighted that we've accomplished those things. So we had really hoped to create more supports for existing providers. So those of you on the line, we really wanted to make sure that not just the accreditation process itself was beneficial, but that once you became accredited, you could really have some type of resource bank that you're going to work through. And so we've done that in two ways, which I'll talk about shortly. The first one is we created a virtual academy, and that's something that we launched a couple months ago. And that's online for all of our providers to go through some of the webinars. So this is an example of one of the webinars that we're putting together. But typically what we have is every month, it's usually the third Wednesday of the month at 10 o'clock Pacific, 1 o'clock Eastern. And we do have an hour webinar that does give you CEUs and does allow you to kind of learn and garner additional knowledge that can help you enhance your practice. So we had a really fantastic one by Manny on pay for performance for those of you who attended. I've gotten such wonderful feedback about that one. And then we had one about treatment integrity and treatment outcomes by Claire St. Peters. And then these are some of our upcoming ones. So please note this on our calendar. We do announce them through our newsletter every month when our newsletter comes out. So our next month is going to be on staff training and performance management by Florence DeGeneres-Reed, and she's one of the most authored researchers in OBM, and she's really fantastic. Ellie Kazemi is going to be doing one on conflict resolution for us on August 15th. And then one of our own BHCOEs, Becca Tagg from Del Mar Behavioral, is going to be doing a webinar on how to best support your RBTs in September. So we're always open to content ideas. If there's any additional topics that you'd like us to cover, you're always welcome to reach out to myself or Christine Ratcliffe, who's been coordinating these webinars. The other area that we've worked on to try and enhance the member benefits is that we've created a partners portal. So what we've looked to do here is partner with organizations who we feel are helping BHCOE accomplish the goal of promoting the highest quality services for their families. So we've created some discount codes here where you or your staff can go on, and if you're accredited, you're able to get discounts off certain things. So some of those includes things like Relias Learning. Others are specific events like the ACT for Behavior Analysis workshop with Adele Najowski. And then we also partnered with 3Pi Squared, who makes employee handbooks. And the really cool thing about this organization is that we went through and collaborated with them on all of their standards so that their handbook is actually BHCOE compliant. So there's kind of some discussion around, the idea of standardized agency documents. And from my perspective, I think that it's really important to find resources that can help us enhance what we're doing. And I think that they do that. They also have a subscription component involved where they basically update the handbooks anytime a new law comes out. So you're not having to rely on paying your legal team to do that. They're constantly in the loop of each of the state laws, which I think is really fantastic. So that next component that we really wanted to do is we wanted to enhance the existing practice standards, and we wanted to do it through collaboration with professional organizations. So that's number 2 there, that kind of bluish color. And we did this in a few ways. We reached out to a couple other organizations who do something similar or who work with other organizations, such as our member organizations. And we attempted to create some partnerships so that we can make sure that our messaging is correct and that we're not fragmenting the field too much and kind of having multiple silos of organizations that are all trying to service the same organization. And we know that as business owners, you guys don't want to be involved in 5 different organizations that offer different things. So we're doing our best to continue that. And if you have organizations you really love working with that you'd like us to collaborate with, where we can either create discount codes or create similar agendas, please let us know and we'd be happy to do that. But one of the most significant partnerships that we explored last year is the partnership between our organization and an organization called the Code of Ethics for Behavioral Organizations. So if you haven't heard of COEBO, it was actually founded around the same time BHCOE did, unbeknownst to each other. So we, someone named Adam Ventura out in Florida had a really similar idea, which is that we really need to be held accountable to some higher standard for our organizations. And he developed this code of ethics. And the ethics code was a credential, so an organization staff could go on and take an exam where they're answering questions about ethics. And what we found once we became aware that that organization existed was that we really wanted to limit the fragmentation in the field. So after collaborating for a year or two on some of these standards, we decided to have COEBO come under the purview of BHCOE. And the providers who were credentialed through them are now working with us to identify which of those areas were really meaningful to those organizations and which areas weren't. And same with ours, what are some of the components that we can kind of combine from both so that that we're creating a universal standard across all of the organizations. So for those of you who are both COEBO accredited and BHCOE accredited, we've already reached out and spoken to you and you're aware of those, but we'll be announcing some of those changes as well, and we'll be determining whether we should keep that exam for some of the employees or whether we should just merge the two holistically, but we'll probably make that decision near the end of the calendar year. And the third component that we've been working on is collaborating with Centers for Medicare and Medicaid, some private insurance, and some state education departments. And so that's that third one there. And what we've really noticed is that most funders are really hoping to identify what constitutes a quality organization. And they're looking for some type of system that's not recreating the wheel and that's not causing a higher burden to the organizations that they're working with. And so for those funder relations, what we're really aiming to do is help those funders standardize their QA systems nationally. So the idea is that there shouldn't be one funder telling you to do one thing and another funder telling you to do another thing, unless there's a good, regional reason for that. So what we've done is we have a couple case studies in which we've been helping funders understand what appropriate outcomes look like and helping them standardize their QA systems nationally. So I'll just go really generally over some of these case studies. And if you have any situations within your region that you'd like us to assist with, we're happy to do it. We typically just do this pro bono as a way to help those states or regions get some uniformity across their area. And it's just a way to kind of smooth those relations. So essentially we tend to act as a Switzerland of sorts in the sense that, we're an independent entity, so we're not a provider, we're not a funder, but we do have a purview of looking at the funder, the provider, and the caregiver, the parent. And so we're able to kind of give a well-rounded approach as to what will ensure that all those components are satisfied. So in one particular case, for example, for those of you who are familiar with the rate cut that happened in Illinois, ILABA had brought us in to meet with one of the funders who was responsible for the rate cut to try and identify an incentive system for what that would look like to incentivize organizations who had achieved accreditation or who had met certain higher quality standards than the ones prior. We've also had some similar relationships with one of the Medicaid states in which Medicaid has brought us in to essentially white label our services. So you might see in one of the states that we can't announce quite yet, but that they will be having QA audits that are going on. If you're already accredited, you don't have to go through that audit process, but if you are, that particular state is using the BHCOE model to go out and accredit organizations or audit organizations to determine competence of the organization and also to determine whether they're providing quality services. And then the third example is kind of a unique one in which one of the funders, Kaiser Northwest, is having us come in and they're just repurposing a component of our audit. So they have their own that they've determined that's kind of setting rates. And in this particular case, we're going in and doing just the surveying components where we're surveying patients and benchmarking it against our internal standard. So these are all different ideas of how we've collaborated. There's certainly a longer list of these folks that we're working with, but if you have anyone that you think would be a good fit for us to go in and try and mediate some of those discussions, we're always happy to do that. So the last component that we've been working on is piloting our preliminary accreditation system. So that's that fourth one over here. And I'm going to talk a little bit about what it is and why we decided to do it. So the first thing is that preliminary accreditation is just a high-level review of an organization where we're looking at the system before it becomes a larger component of this animal that we call the ABA world, right? So essentially what we were hoping to do is create some type of assistance. We'd been getting a couple of requests, and I'll tell you kind of how this came about. So the first component is that we had met with a couple funders who had asked us, because they have a lot of sole proprietors who are providing services, they were asking if there was a way for our organization to identify whether those behavior analysts or clinical psychologists were qualified to provide services aside from the larger entity. And so we had kind of let them know that we typically work with organizations with at least 15 to 20 patients, and we didn't necessarily look at those things for smaller organizations. So that was the first kind of touch point we had where we thought, interesting that that's a request that funders are having that we'd heard a couple times. The second component was that some of the folks on the line here, as you know, have been in communication with us since 2016 saying, we really want to do this, but we're too small. Is there anything that we can do that would be less intensive, less costly, and that sets us up for success longer term? So based on these two requests, we determined that there should be something that allows an organization who's we call emerging to be able to look at their systems and say, are we doing okay? Are we on the path to success? Before we take on our first 20 clients, did we do everything correctly? And what we're seeing is a lot of organizations are kind of doing as they go. And what we'd like to see is that these organizations are really set up for success so that they're reducing their liability and that they're kind of putting their best foot forward when they begin. So it's a way that organizations can either prepare for a full accreditation within a year if they're planning to grow, or it's just a way for someone who's in determining that they want to always stay small to make sure that those systems are in place. So these are the components of the preliminary accreditation that we piloted. So the general requirements were things like, do you have a business license? Are you incorporated in your state? For hiring, we looked at things like templated offer letters, whether they have key ideas of what their salary requirements are going to be for each of the positions and job descriptions. We also looked at things like HIPAA. Are you using a HIPAA compliant email server, email client and a server of some sort. Crystal, I see your question about 3Pi² helping with HIPAA compliance. I do know that they have a HIPAA handbook that they have available, and we have reviewed that as well. And I do know that it's legally and compliant. But we don't necessarily look at whether the handbook is in place. We actually look at the practice that's occurring. So if you're emailing through a Gmail account or a Yahoo account, typically that's something you want to be a bit careful about unless you have a specific BAA with those. What I'll kind of be clear about too is we don't like the idea of monitoring HIPAA. HIPAA is this large animal that's more of a legal issue than a clinical issue, but we've just found a lot of negligence in the area. So we've decided to add this in as a way to protect some of the organizations we're working with, just because if they are doing good clinical work, we would hate for them to be fined this, really fancy fine if they were making an error in that sense. We also ask questions about intake and clinical and consumer protections, so things like, do you have templated assessments and progress reports? We don't dictate what those should look like. We just look to see that those exist and that they're being used appropriately. And then for consumer protection, we're looking at things like, do you have an agreement in place with your patients? We saw a lot of these newer organizations who are operating without any type of a contract in place, or notifying their consumers of the rights that are available to them. What's their complaint policy? So that's what the preliminary accreditation pilot looked at. We just finished piloting it with 5 organizations, of which 4 completed it successfully. And we're actually having a roundtable tomorrow with those accredited providers to talk about how beneficial it was for them, whether they have any feedback for us, and give them feedback about what we found as well. And we just announced that we're now open to starting this process. It's done completely over the phone and digitally, and it takes about 3 hours to go through it, but it's just a really great way to kind of kick off your business and make sure that you're looking at things correctly. So the next component that we we worked on over this last 6 months, and we had our annual board meeting in which we reviewed our standards. And for those of you who have been through the process within the last year, you're familiar with some of the changes we've made, but I'm going to highlight some of the high level changes that we've made. So the first one is that when we started in 2015, we had a 2-year accreditation model in which the organization would be accredited for 2 years independent of their score. And what we found was that we wanted to create some type of incentive system where an organization who earned an 85%, would be a little bit more motivated to maybe earn a 91% down the road. And the way that we did this was creating tiered systems for accreditation. So the idea is that if you receive an 85 to 90%, that means we'll come in a year later and do a reassessment or a reaccreditation evaluation. But if you are earning a 91 to 95%, we don't have to do that for another 2 years. And then that last one is that 3-year accreditation, where if you're really nailing every single item and you're able to meet all of those standards, the idea is that we can come in and review your organization every 3 years, unless there's some large scale change, like a change of ownership or something like that. But typically, if we find that an organization are meeting those standards between 96 and 100, we know that they have really solid systems in place, and there's nothing really that can indicate that they might be having any structural changes down the road. So we've had organizations who've really liked this, especially the ones who want to set a benchmark for themselves to do better down the road. But on the other hand, we also want to make sure that it's clear that the 1-year accreditation is still a really wonderful thing. We have some providers who get a little nervous with the 1 year, but the important thing to realize there is that this is still a wonderful thing. It means that you're widely doing wonderful work. And this is just a way, again, to help you excel to an even greater area. And it's not a negative in any way. And I want to make sure that our organizations feel like a 1, 2, or 3 year, all of those are accomplishments independent of which score you get. And it's just a way to help you move up through those different systems. So the other components that we've changed in our standards are a bit nuanced. So the first one you'll notice is on the left here, you'll see what our standards used to look like. And on the right, you can see we've updated our numbering system. So what we found is that widely it was a bit challenging to refer to some of these standards without clear numbers. So we've updated the standards to have clear numberings based on the component. So 1.0 is staff qualifications, and then we have numbers 1.01, 1.02 after that. We've also updated the name of our standards. So we've updated the name of the standards to the Code of Effective Behavioral Organizations, and that's something that we're going to be referring to them more widely so that it's clear exactly what you're referring to when you talk about the code. And then we also want to make sure that as people are citing the code in the peer-reviewed literature, they have a clear name that they can use when they're doing that as well. We've also added 3 components to the staff qualification, training, and oversight section. So you'll notice this is new in our annual report. So the first addition is that we added in a performance evaluation process review. So what we're hoping to see here is that the providers is utilizing some type of evaluation process that's standardized across their organization, and that they have some type of regular review of performance that's set in. And typically we see it documented by employee progress. So when we come in and do that evaluation, we're looking to see that when we ask for a record review of sample staff, we can see what the performance development system looks like and how often you're collecting those data. The other component is that the provider has a defined organizational structure and hierarchy, and that's a way for us to really get a clearer understanding of the chain of command and the clear responsibilities available to all of those independent workers. And that ties into 110 as well, in which they have job descriptions and expectations. And that's just another component that's kind of feeding off of the already qualifications that we were looking for. But it's a little bit more organizationally focused so that those folks know exactly what's expected of them, and that you're having a bit more accountability in that as well. The second section is related to treatment program and planning. And some of the small changes we've made is that historically what we had done is that we had looked at the individual outcome collection. So we had looked at whether the provider is collecting data and whether those data are being collected regularly and they're being monitored for progress. But as of June of 2017, we began collecting large-scale outcome measures based on some of the requests from those funders and those providers who are asking us to kind of aggregate those scores. So now we are also looking to see that your organization is collecting and monitoring organizational outcome data as well. And for those of you who have gone through the process in the last year, you're familiar with what that looks like, which is having a repository for outcome that doesn't live within your progress report. So typically what we're seeing is that an organization is able to measure progress individually, and to be able to see how that patient is doing, you have to go to their individual progress report to identify what their changes have looked like over time. And if you're using electronic data collection, that's an easier way to do it because everything's embedded in some type of platform. But we want to be able to see, what is your organization doing to measure your success in terms of patient outcomes? So how is that client progressing on average compared to the other patients that you service? And being able to see whether you're able to make changes appropriately. So if you have someone who's not performing as well or kind of responding to treatment as well, you're making changes quickly and pivoting appropriately so that you're not seeing as many stagnating patients. So what we found was that when we were doing this outcome data, we would find all too often some organizations where the outcome measures really did not show any adequate progress for patients. And that was something that was concerning to us, that we wanted to make sure that if we're pulling these data, that the organization is doing it independent of whether we're coming in every year or not. So it's something that we're looking at, whether you're doing it individually and then whether you're doing it organizationally. And then the last component that we added here is that we had before talked a little bit about the supports that we were looking to see for nonverbal or non-vocal children. And here we had some specific language that was geared towards an actual speech language pathologist. And we found that language to be a bit limiting. So we decided to expand that language to make sure that the organization demonstrated general competence in facilitating language acquisition. And if they didn't have someone who could demonstrate that competence, then they were consulting a specialist as needed. And that's a little bit more less restrictive for someone who has a clear understanding of language acquisition and some of those supports that they might need, like an AAC device or PECS or whatever it might look like. And then the kind of big ticket item that we had worked on last year that was really challenging to see was some of the recommendations that providers were making for hours. And so the concept here is that your recommendation is a medical recommendation. So, I always kind of compare it to the idea of, if a doctor says you need a certain amount of medicine, if the funder says that they don't need that medicine, we shouldn't, as clinicians, be reducing our request for the amount of medicine that individual is receiving. So here what we had was we had some language that was suggesting that the provider not alter recommendations for treatment dosage based on a number of different criteria, and instead base those recommendations based on judgment, research, and standard of care. So what we did with these items is, instead of focusing on what the organization should not do, we reworded the language so that at the top, that bolded component there is that the new standard item is that the organization determines treatment dosage based on professional judgment, research, and standard of care. And we've removed some of those non-examples there just so that we can kind of focus on that one area of what we want to see as opposed to the things that we don't want to see. Any questions before I move on to the next section on collaboration? I think this dosage issue is a really challenging one because, we do see some organizations who are making adjustments based on funder pressure, based on parent pressure. And so what we really encourage you to do is stick to your original recommendation. But if you need to make an adjustment, such as a provider needs to say, I recommend 30 hours, however, the parent would only like 20, or however, the funder is only willing to fund X amount of hours, then please make sure to include that in there, because then it creates a challenge for some of the other organizations who are sticking to that larger model and creates a precedent for a lower dosage amount than what is medically necessary. So the third section is related to collaboration, and this section has historically looked at the collaboration that you have with your caregivers, so with the patients that you're working with, the collaboration that you're doing with other professionals, and then within your own organization internally. And so our original language, we found, again, was a little bit too rigid in terms of the stipulations of requiring certain behaviors from parents. So, for example, in the earlier standards, we had that an organization would require caregiver involvement in treatment planning. And so what we decided to focus on instead was focus on behaviors that are more likely to lead to parent involvement. So for example, 3.01 is that the provider notifies caregivers of the expectations for involvement in programming. So that's what we're looking for, is that they have a clear expectation that's being set early on. And then 3.02, for example, is that the provider educates caregivers on clinical outcomes and parental involvement in their child's progress. So some of those other components get at some of these things. So for example, 3.04 shows that the organization has a clear standard requirement for caregiver participation, independent of the patient's funding source. So what we don't want to see is something like, the organization will have a requirement for one funder as being high because the funder pays for it, and another funder because is lower because they don't pay for it. And we know that the research shows that if parents are involved, our treatment outcomes will be that much greater. So we want parent training and parent involvement to be embedded in the treatment model, whether that's something as simple as observing a session for an hour and going through some of the treatment processes that you're putting in place, having parents complete a task analysis, but having those clear goals in place for in-session goals and out-of-session goals for caregivers, and making what we call a reasonable effort to involve caregivers in training, participation, and planning. So what that reasonable effort means is that there are certainly cases where a caregiver is either resistant to participation, or maybe they have certain environmental circumstances where they're not able to participate, like they work multiple jobs, or they have multiple children on the spectrum that make it a bit more challenging. But we want to make sure that reasonable efforts are made, and if they aren't, that they're documented appropriately. So what that means is that if parents aren't participating, you have clear understandings as to why that's not happening, so that you can at least monitor that and make efforts after those circumstances might have changed in the future, or at least work with the parents to try and change those. The next section, and this is something that we've gotten feedback from a lot of our providers on, and I'm really excited to report on this component. So what you'll see in our new standards is that historically, we had two separate sections, section 4 and 5, that were related to access to services and marketing. So the access to services component was, how are you managing a wait list? Are you doing it ethically? Are you giving your parents clear ideas of, what other services exist, what other resources they can go to? And section 5 is related to marketing. So are you marketing appropriately in a way that doesn't exploit your consumers, that is clearly representing what you provide? So for example, if you have photos of your clinic on your website, those should be real photos of your clinic. If you say that you conduct a certain type of therapy, you should be able to conduct that therapy. If you say you speak a certain language, you should have someone on site that speaks that language. Those are just little things that we do get some complaints about. So those are areas that we were looking to do some more due diligence on. But what we found was that some of the concerns were that the areas were weighted too heavily because there were fewer questions in those two sections. And the truth is that when there's fewer questions, that actually means the tool is less sensitive to those issues because it's a less nuanced component. But either way, we did find that combining these sections actually wouldn't change the overall score for the organizations, but it would allow them to get a broader overview of that whole component, which we saw was broadly just called your ethics and consumer protection section. So now the section that's 4.0 is called ethics and consumer protection. And it includes those waitlist components, the marketing and representation, and then we also collaborated with the COEBO to put in some of those behaviors we're looking to see related to promoting ethical behavior. So we do look to see if the organization has an appointment of an ethics officer, how they manage whistleblowing, and how they kind of communicate that to their staff, and then some of those other components that are related to promoting some ethical culture internally. The newer section that we added is that over the past 2 years, our organization did notice a large HIPAA compliance gap in some of our organizations. So they were things such as when we were conducting the audit, we would find that providers were, even though we had a BAA in place that we had provided, we had found that some providers were emailing us client data with a Gmail, a Yahoo, or SVC Global account. We saw that many staff had non-company owned email addresses, that oftentimes data sheets or reports were being housed on personal computers, and that oftentimes there were no data backup plans. So if for some reason someone's computer crashed, all those data would go down with it. So this is a complex topic. And like I said earlier with preliminary, it is something that we've kind of grappled with as to whether we do want to review it. And it's not something that we feel is a clinical or quality issue, but we do believe it's a general compliance issue that we hope to kind of elevate the bar across our organization. So we are looking for this now, but hopefully for many of you, it'll be a pretty easy, freebie to go through, and we'll be able to catch some of those errors early on. I saw a question come through about a minute ago, so I'm going to answer that. So the question is related to prescription of services. Have you identified a standard for providers that is consistent, and are you analyzing methodology for prescriptions? So that's a really great question asked by Kathleen. So I would say that question is probably one of the hardest questions to answer right now in autism spectrum disorders and applied behavior analysis. And I've gotten into some of these conversations with folks over email before. And I think that to kind of talk about why this is an important question and why it's challenging to answer is that largely in applied behavior analysis, our field hasn't really come to a consensus as to what we're trying to accomplish for our patients. So for example, when we take a pill of some sort to cure depression, for example, it's very clear that that pill will cause, let's say, 30% reduction in symptoms, or 20% reduction in symptoms. So we know that if you take this pill, that's going to happen based on this medical model, this medical research that's been conducted. With ABA, we haven't really determined that. Are we looking for a cure? Are we looking for a reduction in symptoms? Are we looking for a remediation in some sort? So I think this is kind of a larger topic that we're hoping to grapple. And I'll talk in a little bit about an outcomes task force that a few of us on the call are a part of, that we're hoping to put out a white paper to really tackle these issues as to not just how are we putting a standard in place for prescriptions, but also what are we looking to accomplish long-term and how are we determining whether that's happening? So it's a very roundabout question, Kathleen, but roundabout answer, but I hope that it kind of gets at the idea that right now, we don't have a great consensus for it, but we're working on it. And today, the literature shows that we should be making those prescriptions based on the child's age, the deficit, their chronological age, their developmental age, their level of impairment, and their receptiveness to treatment. So those are kind of the areas you want to look at. But I don't know any clear models that are really giving you a place where you can plug in information and pop out a recommendation that we're using as clinicians. I know some funders are using it, but as clinicians, we don't have access to that. Another question that was asked was that you'd like to be able to access the information later. Yes, this conference is being taped, so we will be uploading that to our virtual portal and you'll have access to it, so not a problem. So the next component, for those of you who've been through the process in the last year, you've had the pleasure of having one of our auditors come out to the site visit, to do a site visit. So this is a really important component. We've gotten so much feedback about the importance of the site visits. And I just want to, kind of clarify that we always had the desire to do site visits as an accrediting body. But what we found was that when we first launched, and even when we were doing this QA process through the Department of Developmental Services in the state of California from 2009 to 2014, the site visit was something that was really challenging for providers. And so we identified that we really wanted to create like a shaping process where people got comfortable with the idea of peer review, and we wanted it to be a really positive and collaborative practice before we sent someone out to dig a little deeper. So now that we've had that comfort level established, I think it's a fantastic time to roll out these site visits. And anyone who's going through the process in 2018 has had the site visit. We no longer do just virtual audits at this point. But what I will share with you is the components that we're doing, how we're piloting it, and then some of the ways that it's going to fit into our tool. So the site visits began in January 2018. We did have some who went through it voluntarily back in 2017 because they just wanted a little bit more of a hands-on review. We also added in a progress report review, and all those templates are provided to you once you initiate the process, so you know exactly what's expected of you and what we're going to be looking at. So this is an example of the scorecard that we look at. So we select 2 to 3 clients, depending on your size, where we go out either to the home or to the clinic, and we look at some of the areas in which we're hoping to see appropriate behavioral repertoires in place. And so typically what we're doing is we're observing the technician interacting with the patient, and we look at antecedent manipulations, consequences. We look at accessibility of reinforcement, how often reinforcement is being assessed. We look at the behavior intervention plan, whether it's accessible, whether it's written appropriately, and then we also look at the program book or the electronic data collection system to ensure that it's up to date and that data are being collected appropriately. And then on top of that, the progress report template that we put in place is used to inform whether the report is actually corresponding with what's happening in the clinic or what's happening in the home. And the idea is that the progress report is a legal document. So we want to make sure that whatever is being written there is appropriately communicating what's happening in the clinic. And so we widely saw that that wasn't happening in a lot of areas where if the progress report says you're working on these 5 particular goals, we should be able to go into the home if the progress report was done recently and see that those things are happening and that the functions are the same and that the plan is kind of loosely related to what we're looking at. And instead we were finding things like, the report says the child nonverbal, the report was recently written, we'll go out, the child is talking away and has developed some other behaviors, but there's no real record of these changes. So that's what we want to be seeing. So this is an example of how we score it. The key to keep in mind with accreditation is that we need to pilot the tool before we can embed it into the scoring program. So what we've been doing thus far is we've been collecting data on these site visits and progress reports, and we do present it to all the providers who go through it. So you will receive the scorecard and you will get a clear idea of how you're doing. That being said, that number will not be used to calculate your accreditation score until 2019. So it'll give you a good idea of how you're doing in preparation for the upcoming year. And it'll also give us some additional feedback as to how some of our organizations are doing before we put that in, because we will have to create a statistically significant cutoff score for this component. So for now, what we're doing is that we're using the regular scoring tool, but we are having the site visit and the progress report inform the interview component and some of those other areas. So for example, if we notice that data aren't being collected regularly in our site visit, we do account for that in the other scorecard that corresponds with that section. So this is the scorecard that you're probably most familiar with. This is what we've had in place since inception. So it's basically the scorecards on those different areas, including the 2 surveys. And then we had included a category weight in which the consumer protection and social media were weighted lower than those other sections that were more clinical in nature. And this is how we had done it. So the scorecard that we're hoping to get into place for 2019 will look something a little bit like this, which is that that ethics and consumer protection section will be there. We'll add in a score for the site visit. And then that last one, which will be really interesting, is that patient outcome component. And that's something that we want to be very careful about. So I put that in there even knowing that maybe it won't be 2019, maybe it will be 2020. We need to validate those data and make sure that they're appropriately representing patient progress before we have it penalize any organization or have it go in and give you a snapshot of how we think you're doing. But it's something that we're working towards and that we're really excited about. And I think it's something that our field is moving towards anyways, and something that's going to be really important longer term for our field. Any questions about the updating scoring system or any of the standards that I went over? I wanted to move into some of our disciplinary policies, and I'm going to go into a little bit more about the outcomes as well. And we have about 15 minutes left, so if you have any questions, this would be a great time to jump in. All right, so let me just move in, and then I'll be monitoring the QA tab for questions as they come in. Good question. So the question was, who pays for the site visit? So that's a great question. The fee structure that we've had, for those of you who have been with us since the beginning, we reassess our sliding scale every year. And that's just based on the cost of doing business and the cost of it the cost to go out to the site, the cost is to process all these data. For those of you who have been with us in 2015 and 2016, you stay in the sliding scale in which you are first admitted into. So we do not increase those prices for those organizations. The only change that we have is an $800 site fee. So that is the cost of hotel, flight, and the time of the BCBA to come out and do the full day site visit. Typically what we've had is if we happen to have a provider who's local to your organization, we do reimburse at cost if it's below $800, but typically $800 is what we've seen as what that cost is. And sometimes it goes over, so we do eat that cost and we don't charge anything in addition to that. And for those of you who are about to reaccredit, what we'll do is we do just review your size again, and we'll update you to the bracket that you're in based on that. But our costs, we've tried our best to keep our costs low. Again, we think this is important for the field on a larger scale. So we never want cost to be a deterrent. So if cost is ever an issue, please talk to us, because we, want to work with organizations who care about quality. So we never want the reason someone's not doing this to be because it's out of their budget. Okay, so the next component that I just wanted to touch on a little bit is 3 things that we've added to our engagement letter, and 3 areas that we've kind of added to either our engagement letter or to our policies. So the first one is that we added a recent requirement to notify us of a lawsuit being filed against the organization. And the reason that this is important is because we have recently had some organizations who have been going through some legal issues, and because it has a direct relationship to quality of care, we just want to be apprised of it and make sure if there is any illegal activity occurring, we are able to review some of those areas and make sure that we're in the loop about what's going on. And what you'll find is we have worked with some organizations who either have gotten into the news for some reason or have been accused of certain things. And what's really been wonderful is that we've been able, with this new stipulation, we've been able to go in and review all of the documentation, all the legalities of that, and determine for ourselves as an organization that that particular provider is, free of any any issues. So that's been really important to us, and I think important for all the providers in our network as well, to ensure that you guys know that anyone who's in the network with you has been vetted by us appropriately. The other component is that we have had some organizations who are non-passing, so they kind of fall below that 86%, or they have significant issues where even if they are within the range of passing, we're not able to grant an accreditation decision. So that's something like, maybe they did meet that 1-year accreditation standard, but maybe they have some really serious accusations from staff related to some unethical behavior that we're hoping that they can take that feedback and work with it. So what we've decided to do is create a provisional accreditation status where we essentially provide them with a resource bank, and we're in the process of creating that because we don't want these providers to feel penalized. We want them to feel like supported and have a network that can help them do better, especially when they're servicing so many patients. We don't want them to feel that they're not adequate. We want them to be able to feel empowered to do better and to improve. So that's something we're working on. The other component is that I wanted to just share with all of our providers here about some of the complaints that I often get. So I've gotten some questions about, we really want to go through this again, but I can't believe you accredited provider X, or everyone leaves provider X to come to us. Are you sure they're quality? And, I get a lot of these statements, and it's fair because we, as a field, we haven't had the mechanism to rely on data when it comes to assessing organizations. We've had to rely on anecdotal evidence, which is word of mouth or, gossip. So what I'd just like you to be able to share with your staff, if you hear anything like this, is to kind of remind them that we should be operating off of database decisions about how we feel about an organization. And for those of you who've been through the accreditation process, you know that it's a rigorous process, and you know that it's not easy to achieve accreditation. So just know that if we do accredit an organization, that means we did go in there, we did, floss their teeth and checked on things. That being said, if you do have a significant concern, I would absolutely encourage you to put in a compliance complaint, and that can be found on our website, and that is there we encourage everyone to, that is there for your protection, for consumer protection. So if there's a significant complaint about an organization that we've accredited, that's why it's there, so that we can go in and investigate for ourselves. However, we do need evidence of those behaviors. So saying something like, I've heard that they do this, that's a bit challenging for us to investigate on. But if you have very clear ideas that there's something illegal happening, or there's fraud, or there's anything like that, please, please, please use that form. It's there for your protection and for our consumers' protection. All right, I was going to go into some of the outcome analyses data, but I want to be a little cognizant of time. So I'm just going to quickly skim through this and go through some of our benchmark data. So this is the outcome data that we now collect for all of our organizations, and this is an example of some of the data that we're collecting for you, so that you can have a good idea of variations and improvement over time. And this is what this provider task force is looking to do, is kind of identify how can we represent quality care and assist our network in showing their clinical success. And I'm really excited about some of the members that are going to be participating in this. And we hope that by the end of the year, we'll have a really wonderful white paper to kind of share what we're seeing our providers are doing related to outcome, what some of the natural pitfalls they're making, what are some of the common mistakes that we shouldn't be making when collecting outcomes, and then what can we do to kind of better do that. So that I'm going to quickly go over that. And then if you have a chance to review our annual report, we also put out some of our turnover rate data. And what's really exciting about this is quite low compared to some of the research that's out there related to just general organizations. So what that means is that we're seeing the providers who are passing accreditation tend to have a lower turnover rate than providers who aren't passing accreditation. And I think that's really important, that's a really important correlation that for funders and for parents as well, to know that if someone's accredited, that means that they have some type of more significant relation to quality. And then that's what you're seeing with your technicians as well, which is about 35%, whereas some of the literature we're familiar with is more about 50 to 60% turnover, which is what you saw back in 2015 and 2016. We also put out some hourly rate data, and we've gotten some cool feedback about this. This is just on aggregate across the thousands of technicians we survey, what their hourly rates look like. And it looks like the median rate here is about 16 to 20 an hour. That being said, we are moving to having this being reported by the organization instead of having this being reported by the technician. So we have gotten some feedback that when we provide those individualized data, some providers say, we actually don't pay that much, that's not accurate. And so now that we've gotten feedback that providers are open to disclosing that to us, we will be requesting that from you if you're interested in it, because we do want to paint a more accurate picture of what those rates are looking like. And then same thing with BCBA hourly rates. So we're seeing that on average, you kind of have these entry-level BCBAs who are coming in about $30 or less. And then as they move through the senior leadership positions, they're getting paid more. And of course, there's different considerations for cost of living. And we're going to be putting together a larger scale analysis on these that's accounting for cost of living, hopefully in 2019. So I'm excited about that. And then lastly, what I'm excited about is that every year we put together our Best in Class Awards. And this is something that in which we pick the organizations who've done the best who've done the best across all those different domains. And so what's fun here is that we look for organizations who have at least 25 patients and 25 employees, only because that really does skew the data when you have a smaller sample size. So for those of you who are smaller, we can't wait till you're bigger so we can add you in here, but just know that some of our smaller organizations do have really great satisfaction and patient satisfaction and staff satisfaction, but because they're so small, we just wanted to make sure that it was a fair game. So what we found was that for patient satisfaction, we had two organizations, the NAP Center in Ohio and then Connections in Washington, and they were the best in patient satisfaction for 2017. We had a tie for 3 in terms of staff satisfaction. So Little Leaves in Maryland had highest staff satisfaction, Love to Learn in Orange County, California, and then Alternative Behavior Services. And this one's exciting too because they're in 3 different states. And for those of you who have larger practices, it's tougher to maintain that quality as you grow. And they're based in Utah, North Carolina, and California. And then our last overall overall clinical quality winner was the Knapp Center again in Ohio, and they scored highest across all the domains and had the highest overall score. So if you know any of these folks, please congratulate them. And give them a shout out. So what I'm going to do is I'm going to end with our featured directions and then take some questions for those of you who are still here. So our featured directions are similar to what we want to continue doing, what we did last year and what we hope to do. The first is continue to promote quality standards. The second is expand our membership to 50 states and increase our international reach. We've been really fortunate to have some wonderful providers in Australia and Canada. We just worked with a provider outside of the US that was doing really wonderful work in underserved areas. And we have some other providers that we're planning to work with in the Middle East. So we're excited about that. And I think that this is something that we can all get behind, is that quality services should exist independent of where that child is located. The third one is that we really enjoy collaborating with some of these states and these funders, and we're going to continue to do that. And some of those case examples that I gave you earlier are examples that we're in deep with right now, and we're continuously working with them, and that project hasn't ended yet, and I'm hoping that down the road we'll be able to share some of that work with you. And then lastly, we want to continue providing support and resources for our network. So if there's anything that we can do to make your practice easier and to support you better, please don't hesitate to let us know. Right now it's through that virtual portal and the partners portal, but we're certainly open to more ideas as well. Well, that takes us to 11 a.m. on the dot. Thank you all for joining us today. It's a pleasure working with each and every one of you, and I'm really looking forward to the year ahead of us. If you have any questions, you can email me directly. And please keep in mind the upcoming webinars that are going to be the third Wednesday of every month. We have some really great lineups. So I hope that we see you in July. Thanks, and have a wonderful rest of your week.